Let's talk about restorative reproductive medicine. I'm Dr. Jessica Rennick, a double board certified OBGYN and REI, and I just attended a town hall at the American Society for Reproductive Medicine annual meeting all about RRM. And it was a very powerful, thought-provoking, and honestly a little bit emotional conversation for me, and so I wanted to share my probably very disorganized thoughts here. According to the International Institute for Restorative Reproductive Medicine, RRM corrects underlying causes and contributors to infertility and reproductive dysfunction. You'll hear a lot about root cause, getting to the root cause and correcting it. RRM focuses on the question, what is wrong, and then aims to restore or optimize natural function without suppressing or bypassing the problem. So this slide here tries to show what RRM includes. So that's cycle tracking, cervical mucus, basal body temperature, ultrasound to prove follicle rupture, hormone levels throughout the cycle. Male factor components would include treating the underlying health conditions, and that might include some hormonal treatments like Clomid, tamoxifen, HCG. From a diagnosis and testing perspective, you can see here some of the exams that they will perform, and then you can see here from a treatment perspective, it mainly focuses on lifestyle modifications, oral ovulation induction agents, again, like Clomid, tamoxifen, letrozole, and then really kind of trying to optimize the cycle, optimize the cervical mucus, progesterone luteal phase support, surgery, and then some other kind of inflammatory or underlying medical condition treatments. And honestly, like as a fertility doctor, this is all fine. Like in a history, personally, I will go through someone's cycle. If they have cycle tracking apps, I will encourage them to share their data with me, and we can kind of try to go through and figure out if there's any kind of subtle issues with their cycles. And a lot of times we do identify these things, and then we can work to optimize them. The testing, again, a lot of this is what is included in a fertility doctor's evaluation, although there are some kind of non-evidence-based things here, like the NK cells, the CRP, endometrial biopsy, not everybody needs. Serial ultrasound, probably not necessary, but no real harm in this approach. And then again, like the treatment options that are listed here, most of them can be something that you do along with fertility treatment or as a first step. And the speakers took this information from one RRM provider's website showing the different phases, kind of summarizes the same things. So phase 1 is diagnosis, and that can take, 1 to 3 months. And I think like one of the big differences here and issues here is phase 2, where they attempt to try to achieve ovulation, give prescriptions as required, follow follicle tracking, hormone blood tests, and then surgical referral if necessary. But this phase 2 part can take 12 to 18 months. And so that is a long delay potentially to more successful treatment options for a specific person. And then you get to phase 3, where the thought is that they've optimized hormone levels and your cycle, and then you go try to conceive for up to a year. So that's another year added onto the journey with RRM. And then hopefully you get pregnant, and they provide pregnancy support with early pregnancy monitoring. But this is very different than traditional fertility treatment pathways. We are trying to go from testing kind of right into a more active treatment approach, which, maybe is not right for everybody, but we know that there are significant impacts of time and increasing age on success of ultimate fertility treatment. And so waiting 12 to 8 months to try to balance your cycle, and then another year of trying to conceive past whatever you had already tried to conceive before presenting to someone, that can be a really long time. This may not be super impactful for younger patients, but older patients that are trying to conceive may not have that time. There are also people who RRM will never work for. So hypothalamic hypogonadism, that is when the brain is not sending hormones to the ovaries to stimulate the ovaries. Oral medications will not work in this scenario because the brain has to be working. And so you need injectable hormones in order to get pregnant with hypothalamic hypogonadism. Severe oligospermia, congenital bilateral absence of the vas deferens. No amount of hormones is going to get sperm in the ejaculate of someone who does not have a vas deferens. Severe bilateral tubal disease, patients requiring donor gametes, and patients requiring gestational carriers or surrogacy. And another big difference is who these treatments are for. So with RRM, they focus on heterosexual and mostly married couples. That could exclude partnered heterosexual couples, LGBTQ people, single mothers by choice, and single fathers by choice. And that's a big problem. Some of the other problems we discussed about restorative reproductive medicine is that there's very little oversight and governance of what RRM groups can say and put on their website as advertising for their services. So for example, the majority of fertility clinics in the United States report to SART. That is a reporting agency where we give our outcomes every year for everybody that's gone through IVF cycles, and they put it all together and release reports that show specifically how each clinic does, looks at live birth rates and a number of other different factors, and you will get kicked out of SART if you publish incorrect and inaccurate data on your webpage. RRM does not have any kind of reporting agency like that, and we went through a bunch of different examples actually of RRM websites that were claiming things that could have come out of nowhere. And that's a problem. You need to be honest with patients about what you can offer them, and that leads to another really important point, that RRM providers are not obligated to talk about alternative treatment options. And what I mean by alternative treatment options is not like acupuncture and things like that. It means that IVF, IUI, as other treatments for fertility outside of what they provide. And this is important because in order for someone to make an informed and educated decision on what they would like to pursue from a treatment perspective, which is very important, informed choice is very important, you need to know what all of the options are. And RRM providers are not obligated to tell you that IUI and IVF are an option. They're not obligated to provide a referral to someone who provides that care if that's something that you're interested in seeking. Or maybe you don't even know that that's an option. And a good way for me to demonstrate the difference here is that I don't perform reproductive surgery anymore. I do small surgeries, so like septums, fibroids, polyps, things like that. And I was trained to do bigger surgeries like fibroid removal, big endometriosis surgeries, tubal surgeries, but I don't do that anymore. Some patients that come to see me potentially would benefit from a surgery to reverse a tubal ligation or repair the fallopian tubes. While I do IVF, that is a treatment for those issues, I still tell them that surgery is another option for that. And it is important that they know that so that they can make an informed decision about whether IVF or surgery is the best pathway for them. if they never knew that surgery was an option here, they wouldn't be fully informed in making their decision. And that is one of the problems with RRM. Okay, I want to go back to the success rates that they claim and also the time to a successful pregnancy. And the speakers shared this study, and I thought it was very powerful in showing the results. So a lot of the RRM groups claim that they can have as effective treatment results as IVF. And this showed comparisons between groups that did restorative reproductive medicine in Ireland 2018, USA, UK, Canada, and Poland in 2022, and then US in 2019. And you show here too, I mean, the first line there in Ireland, 2 years, only an 18% live birth rate, which is actually not comparable to IVF. But you can see here, the second RRM group and the IVF group both had a 44% live birth rate. But here is the big difference. With the RRM group, that took 3 years to show the same benefits as one IVF retrieval in the United States. 3 years versus one retrieval, which is, maximally about 6 weeks of your time, with a frozen transfer, maybe 10 to 12 weeks of your time. That's a huge difference. And again, we know time is really important when it comes to fertility. So then we came to the town hall portion of the conversation, and I really, really valued this piece of the discussion because I think this is a really nuanced position here, right? As fertility doctors, we feel that we are providing much of what RRM has to offer without the restrictions of not having IUI and IVF as potential treatment options. We feel that time can be of the essence, and so we're providing a potentially quicker pathway to someone's ultimate goals. But I think we have to acknowledge that there is a reason why people are looking at things like RRM in place of traditional fertility treatment and medical care. And there is a very widespread mistrust of traditional medicine right now and of reproductive endocrinology and infertility specialists as a subspecialty as well. And we can't blame people for looking for other options, and they really do a good job of pinpointing where people are having frustrations in what we can offer. And I think, honestly taking advantage of that a little bit by saying, the buzzwords, root cause, and, correcting the underlying things. But we know from the prior discussion that that's not always possible. One of the biggest frustrations as a fertility doctor is having things like unexplained infertility and unexplained recurrent pregnancy loss, which I always try to make super clear to my patients. That does not mean that there is not anything wrong. You are valid in your experience. It just means that we don't have necessarily a test to figure out exactly what it is. And sometimes IVF is the test for what it is. And once we get the eggs and the sperm in the lab in front of us, we kind of get some more information. But it is truly something that I know is really, really frustrating for patients when I can't tell them this is what is going on. And I think RRM takes advantage of that. But going back to the mistrust, one of the first people that stood up and spoke was from Australia, and they shared that their field has had a lot of mishaps and a lot of really harmful things that have happened to break the trust between patient and provider, and they've been working at building back the trust. And I do think that that is something that we can do better as a specialty as a whole. And that's why I think this is really kind of a nuanced discussion. I think we need to acknowledge what has brought us to this position and the lived experience of patients and people who are seeking fertility care, but also offer them all of the tools that can help them achieve their goals. I don't think RRM does that. I think it's a discussion of what RRM is and how it restricts potentially access to other and potentially more effective treatment options versus who supports the concepts of RRM. So a full evaluation, optimizing steps before getting to something like in vitro fertilization, looking at lifestyle, looking at cycle charts, taking that information, optimizing chronic medical conditions, while also offering other fertility treatment options if they're necessary. And another issue comes when this is picked up by lawmakers, because a medical decision belongs between a person and their medical provider without politicians and lawmakers interfering. And when RRM is promoted or offered as an alternative option to traditional fertility care, it becomes a problem because research funds can be diverted. What people are able to access in their state or federally becomes altered. And we didn't hear anything about RRM in the recent Oval Office announcement. And someone did stand up and say, reporters shared with them that they were told you will not hear restorative reproductive medicine in this announcement. But we did hear root cause, and we did hear natural restoration of fertility, and we did hear, American couples and families. And so I think those were all really kind of subtle nods towards that. And that is where it becomes a big problem, because it could restrict access to care even more than whether you see an RRM provider or a fertility doctor.